collaboration with USAID India in 2019, mainly to galvanize corporate support towards the fight against TB. Today, we have more than 250 corporates who are engaged as part of this initiative. In the last 3 years, the Corporate TB Pledge initiative has evolved to become one of the largest programs in the world for corporate engagement for TB. The initiative has been able to forge numerous innovative partnerships by corporates from diverse sectors like tea, hospital, cement industries, and so on. Over 40 corporate-supported projects have been initiated in the last 2 years, including numerous CSR-funded TB-related projects and TB-free workplace interventions. It is an integral part of the multi-sectoral engagement. Ladies and gentlemen, the session on sector and population-based engagement and implementation model will provide an opportunity to learn about successful models on working with different sectors and populations. The session will have presentation by representatives from corporates including Goodrick Group, Jubilant Bharatiya Foundation, Fujifilm, Naira Energy, and Medanta. May I request the session moderators, Dr. Bharati Kalottee, Project Director, Akshaya Plus from the Union, and Mr. Ashish Verma, National Consultant from the Union, to please take over from here. I have a request for the virtual audience. If you have any question, please raise your hand towards the end of the session, and we'll unmute you to take up the questions from there. Over to you, moderators. We'd start with a small video of Corporate TB Pledge initiatives. Can we have the video on Corporate TB Pledge?
With only 2.4% of total land area and 16.7% of world population, India accounts for 26% of global TB cases. 1,200 people die every day due to TB.
Tuberculosis is an infective disease which is eminently curable. Apart from suffering, it also has huge social and financial implications.
To aid the national TB elimination efforts, Government of India and USAID came together to launch the Corporate TB Pledge.
The Corporate TB Pledge is a platform to recognize corporate contribution in India's fight against TB.
Corporates can play a very important role in this aspect by making available the free drugs and diagnostics in the public health system accessible to its beneficiaries.
More than 200 corporates from various sectors and business associations have joined hands to end TB from both the workplace and community settings.
We are going to work tirelessly with the government to actually achieve the goal of end of TB in India by 2025.
I appreciate the efforts being taken across corporate leaders to truly advance this important goal, and I'd encourage you to recommend that your peers join the Corporate TB Pledge as well.
TB needs urgent action from the whole nation.
भारत भी 2025 तक टीबी मुक्त होने के अपने संकल्प को पूरा करेगा, ऐसा मेरा दृढ़ विश्वास है। कोई भी बीमारी को खत्म करने के लिए मल्टी सेक्टरल इंटरवेंशन की आवश्यकता होती है।
With renewed commitment and collaborative action, let's embark on the journey towards TB Mukt Bharat.
So welcome back, everybody. Good morning to all, and hope you had a nice short break of TB. So we start our second session for today on the Corporate TB Pledge and multi-sectoral engagement with the key words we have heard from our Honorable Prime Minister that multi-sectoral engagement is one of the major key priority areas for the National TB program to achieve its goal of TB elimination by 2025. So we know there are lots of efforts. We have been hearing since morning how this is an important component, and various industries, both from the public and private sector, have come together to do some tremendous work there down at the ground level, which we would be sharing today during this session. The session is basically on the successful intervention models, which have catered to a wide spectrum of activities and successful strategies by the corporate TB pledge holders. So we welcome all of them to share with us today the workplace interventions models from the T sector, innovative models on engagement of youth, X-ray screening focused public-private and private-private partnerships, and also a very successful partnership model on corporate hospitals for mobile screening and DRTB services. I would also like to highlight here that the Pradhan Mantri TB Mukt Bharat Abhiyan, which was launched by our Honorable President of India recently, will be reflected in one of the presentations today, how nutritional support has been provided to the TB patients by Nayara Energy, which is working in the Devbhoomi Dwarka district of the state of Gujarat. So without much delay, I would like to invite on the dais our eminent speakers for these 5 presentations today. May I please request Dr. O.P. Prasad, Chief Medical Officer, Godric T, Assam, to please take the dais. Please. Please, sir. Mr. R.C. Satyawali, National Head DR and X-ray from the Fujifilm, to please be on the dais. Mr. Deepak Arora, President, Public Affairs, Nayara Energy, to please take the dais. We also have Mr. Vivek Prakash, Vice President and Head CSR from the Jubilant Bharati Foundation, who is joining us online. Welcome you, sir, there to join us online for this session. And Dr. Burnali Datta, Director, Department of Respiratory and Sleep Medicine, Medanta, also joining us online. But we also have Dr. Arun Jaiswal, the Senior Director from the Department of Respiratory and Sleep Medicine from Medanta. I would request him to please take the dais. He's not there? Okay. So we'll continue with our virtual sessions. And now I would just hand over to my colleague Ashish to take over the proceedings from here onwards for the next presentations. Over to you, Ashish.
Thank you so much, Dr. Bharati. So this is a very important sessions 2. Basically, we will talk about the sector and populations-based engagement and implementations model. So we have 5 presentations in a row. Before moving ahead, it is again better to set very basic rules. So as we know, the 15 minutes has been allocated for each presentations, and would request all presenters to kindly complete presentations within the given allocated time. And the first is, to begin with, let us first understand the first presentations, which is the population-based engagement model in the tea sector of Assam. So as we know the importance of tea sectors, the interventions model has been established for reaching out workers engaged in the tea sectors with TB awareness, prevention, and control drive by the Godric Tea. So today we have with us Dr. O.P. Prasad. Dr. Prasad is MBBS, PG, DHHM, is working with Godric Group Limited as a Senior Chief Medical Officer. He has 40 years of professional experience of working amongst the communities, providing preventive and curative services, and has keen interest in public health. He is a life member of Indian Medical Association, Indian Society of Health Administrators, Bangalore, and the Administrative Staff College of India, Hyderabad. So over to Dr. Prasad for your presentation.
बढ़ता जाएगा। ठीक है, Good morning, everyone. Respected chairpersons, dignitaries, colleagues, and friends. It gives me great pleasure in presenting population-based engagement model in tea sectors in Assam. I am Dr. O.P. Prasad, working with Goodry Group of companies based at Kolkata. The Goodry Group of companies is a part of Camellia PLC. It has 29 tea estates. The first slide.
Yeah, it's yours. You can go next.
It has 29 tea estates, and we are engaged in cultivation, manufacture, sales, and marketing of tea. We are present both in Assam and West Bengal, including the Darjeeling Hills. 1.8 lakh population of workers and families reside in the tea states, and they are dependent on medical facilities on us. We have got 33 hospitals and 3 dispensaries, and a strong and dedicated team of doctors and paramedical staffs based in the garden. The tea garden population is roughly varies from 5,000 to 10,000 depending on the area under cultivation, and they are all remotely situated tea states. The Goodry Group, we signed the corporate TB pledge as a diamond member in February 2020. We started TB-free workplace interventions in the gardens of Assam and West Bengal. We aimed at a betterment of our company employees and their families and community. Thereby, we are championing the cause of TB elimination by supporting reach to other corporate partners. We have our commitment. We commit to ensure that all our staff have access to information about TB and its services. We will ensure that all our staff are periodically screened for TB and linked to diagnostic and care. We'll support all our staff with TB in completing their treatment. We'll ensure employment security to all our staff affected with TB. We have zero tolerance to stigma and discrimination against people suffering with TB. We ensure a healthy workplace with minimal risk of spread of airborne infection. Our workplace interventions consist of, like we are covering about 2 lakh of population. We have got 360 degrees awareness through peer educators and master trainers. The periodic screening, since we have got a doctor there based in the gardens, so it's a continuous process. We keep on screening. We have a residential population also, so they keep on coming to the dispensaries and the hospitals. Recently, we got a CBNet machine in one of our tea states in Assam, and I'm thankful to Fujifilm Limited for kindly providing us this support. It's very, the treatment adherence support to the TB patients are provided by us. The medicines are supplied by the government, but the adherence support, etc., we look after that. We have got sufficient infrastructure, like we have got the 4 DMCs and 1 CBNet machine, and the Nikshay IDs have been provided in all the T states of Assam. The TB and workplace policy and the committee formation. We have formed an apex committee with chairperson and 6 members from the top leadership. Our MD is deeply involved in this program. The terms of reference of the committee is based on the draft shared by the union. We are getting technical support from the union. The apex committee meets regularly. The committees are also formed at the garden level. When we meet, we discuss about anything latest additions on the TB, either on the preventive side or on the treatment side, and then we take a call. The committees are also formed at the garden level, which is headed by a garden manager, the medical officer, the welfare officer, and the representatives from the labor union. The tea industry is guided by Plantation Labor Act. There is adoption of statement of commitment. And our TB policy, we recognize that TB is a workplace issue and anyone can get. TB is preventable and curable. Prevention will be our primary focus. We commit to treating everyone equally, including persons with TB. We commit to providing safe work environment to minimize the risk of spread and impact of TB. We will promote cooperation and trust at our workplace by initiating social dialogue. The access to personal data relating to a worker's TB state will be issued by the national and organizational rules of confidentiality. We will maintain strict confidentiality. The TB status will not be a cause for the termination of employment. We ensure that he gets his wages regularly. Employees with TB will be offered support to access medical services and benefits provided by the Government of India. And we are committed to its elimination by 2025. The training of master trainers have recently been concluded in Assam by the union. We are getting a lot of technical support from the government and the union. The support in forms of policy, the commitment, communication materials. We have also developed our own communication materials to be distributed amongst the masses. The training of master trainers, doctors, and paramedical staff is being continued regularly. The CBNet machine, as I mentioned, the donation was facilitated by the union. The technical guidance in improving data recording is also provided by the union. Documentation and evaluation of projects, they look after. We were included in the best practices compendium, which was published by the CII and the union and the USAID. On 24th of March, on the World TB Day, our activities got some recognition by the Joint Secretary, Ministry of Health and Family Welfare. The key achievements, like we cover about 2 lakh of population, 44,020 symptomatic screening was done. It is symptom-based. 11,914 were tested for TB. 422 TB patients were initiated on treatment, and 10 MDR cases this year. This 10 is inclusive of Assam and Bengal. In Assam, we have 3 MDR cases. We started TB preventive treatment also as per guideline with INH, and 323 patients are under TPT at the moment. The learnings are, the TB intervention at workplace is not a cost-intensive program. Ours is a residential population, so it becomes very easy for us to manage. It helps in improving health and productivity in the long run for any industry. Support and coordination with technical agency and government is critical, which we are getting. We are getting full support from the state TV office, the district TV officer in both Assam and Bengal. The interventions are customized. Mobilization and support of the top management have helped us tremendously. There's a peer-led approach that has helped in reducing the stigma. It was very much prevalent. Nowadays, in our T states, it seems that it is reducing. The technical support has helped in the meaningful outcome and dissemination, and the partnerships have helped in improving infrastructure and efficiency. We expect to improve further on our infrastructural facilities and increase the efficiency on diagnostic side so that we can reach the goal of TB elimination by 2025. Thank you. Thank you so much.
Thank you, Dr. Prasad, for that wonderful presentation. I think it is one of the best workplace policy models which we have been able to demonstrate with your initiative and the effort which has gone there down at the ground level. And it's very overwhelming to see that how the entire cascade of care has been taken care of. So you have started right from the advocacy of the community, you have started with their awareness, coming to the screening, the diagnosis, and then also giving them the treatment support. So an excellent model of workplace policy. You have also seen in some of the slides how the MOUs were developed, what technical support has come from different partners like the union, WHO, and the national program, and how this has been a very successful model. We'll open for discussion and questions post completion of all the presentations. My heartiest congratulations to the Goodrick Group, sir, from the entire NTP program, the union, and everyone here in the audience for the good work and the support you have provided for the National TB Elimination Program. Big applaud for him, sir. Thank you so much. So we move to the next session now, which is on youth engagement model for TB awareness. A very upcoming area, a new area where youth is one domain which is going to contribute dramatically to the TB elimination efforts of the country. So youth participation is very necessary to bring in these changes, and they have a mission, and they can form a mission towards elimination with the new ideas, innovations, and the strength and the support we can get from this youth organization. So moving ahead, we have this presentation from Mr. Vivek Prakash, who has joined us virtually. He's the Vice President and CSR head for the Jubilant Bharati Foundation, having 25 years of experience in manufacturing industries. He's been associated with the foundation for the last 15 years now, and his current responsibility includes strategic corporate CSR planning and monitoring aligned to corporate business needs. And I think we should congratulate him for the good work and the actual strategic initiative which has come in for the TB program from this part of the organization. So let's hear from Mr. Vivek Prakash. Over to you, sir, to present virtually for this conference. Thank you.
Thank you. So this is a program. So am I audible to all?
Yes, sir.
I'm getting some echo. So thank you for giving such opportunity where we can share some of our effort towards this initiative. So TB is not the subject for any one stakeholder. So it's as Prime Minister said, we need multi-sectoral approach to eliminate TB from our society, from our country. And every stakeholder need to act upon it. As as per their capacity, as per their requirement also. So based on this principle, we also started working on this. So we activated our team, our CSR team into this, and so we thought how to bring some innovation into this project. So that's why let me first explain about our foundation. So it's a foundation, Jubilant Bhartiya Foundation. It's a part of a Jubilant Bhartiya Group. And foundation is a not-for-profit organization responsible for conceptualizing and implementing CSR for the group. So we are mainly working in 6 states at different locations. So these are also uh, available on this slide. So we are working on education, health, livelihood, rural development, social entrepreneurship. But I will not speak much about all this. These are available on our websites. So coming to this project, so why we are working on this and how we are working on this, and how how it is unique in terms of approach to handle this tuberculosis. So we are having more than 7,000 employees. So our first approach was how to engage our employees into this project and bring them into this project. So it will not only generate awareness among our employees, they will also understand how TB spreads and how they can protect themselves. At the same time, because if they are working in a corporate, in a company, in a factory, so they are having resources. So how they can also contribute their resources for this cause. So and this time I'm saying first time where government has openly taking support from every stakeholder. And union is working on bringing corporate support into this, so bringing all the corporates, many corporates into this fold. But in fact, credit goes to government, which is working on getting support from each stakeholder to eliminate TB from this country. So this is so the best part is that now everybody is thinking on that line. So how even in our company we are thinking how we can engage all stakeholder of our company into this for this call. So employees are the main pillar of any organization. So that's why we thought why not to engage our employees through awareness and getting their support. So they are not just getting awareness session, but they are also coming up with a nutritional support, because TB patients need nutritional support also during their treatment. So we also received a lot of requests from district tuberculosis officer at different states and different blocks where our plants are there. So we requested our employees to come forward and support the nutrition part. So that is one part. Another is participation of participative community awareness. Here we did some innovation because youth are power of this country, power of our society. Why not to engage them? Again, here there are two benefits. First thing, they will be aware about tuberculosis. They can protect themselves, but at the same time, they will learn how to volunteer for the society. And so we are in motivating them to do something for the society. So what we did, we first trained some of our employees at each location, especially our occupational health staff, then our community health officer, then our coordinators, and they got certificate from, in fact, WHO also. So there is a very good portal through which our entire group gone through this training. It's called Swasthya E-Gurukulan, and they got certification also. It's a feather in their hat, in fact. So they got certification. Now they are, so we have taken target to train more than 1,000 volunteer from the community. So now, so we are moving to colleges or inter colleges and motivating youth to become volunteer for this. And each volunteer further they will take one village for their project, and they have to accompany ASA worker and Anganwadi worker in their target village. They have to visit each and every household of that village and generate awareness. At the same time, they will also carry the sample collection box, so that the people who are having some symptoms, they will provide their sputum for the test to the ASA worker, and further it will go to the government system, so that they can go for test, and if they are screened positive, and then they will go for the treatment, because government has already created entire infrastructure for the treatment, but we need to expedite this entire thing through this volunteering. So that is our thing. Then nutritional support, as I explained, employees are supporting, and we are also supporting from our in fact CSR fund. And so this is the project through which we are trying to reach out to the community, and then generate awareness, and then eliminate TB from not only our workplace, but from our surrounding area also. So these are some details of the project. So you can see here 1,000 volunteer will cater around 2 lakh population, 2 lakh household. So, and further we can reach out to 10 lakh population, 1 million population. So it's a small step, but again, we want to fortify this entire effort of government, which is working to eliminate TB from our society. So everybody will get benefit. We will also get benefit if TB will not be there in our society. So thank you. If there will be any question, these are some photographs of how we are working. So our coordinators are going to schools, motivating students and youth to become part of this entire initiative. And next way forward, as our previous speakers said, that workplace intervention program is also required. We had workplace program on HIV/AIDS, so same way, the same committee, again 175 employees are being trained by as master trainers, and they will further go to at floor level, and they will organize workshop for the employees, and further we will do screening of our entire workforce also. So that is also in our future plan. Thank you from my side.
Thank you, sir. Thank you very much for such a nice presentations. You talked about youth policy model, and that is required in national tuberculosis eliminations programs. You also talked about the need of workplace policies and workplace interventions, and that we need to learn, like for any industries, it is a commitment, like how better they can address TB through workplace policies, and it is effective implementations at the workplace. Thank you very much for your presentations, and we understand the importance of youth engagement in TB programs. So youth can be a brand ambassador and can take the initiative forward for further TB awareness, preventions, and control drive. Next, we have another presentations on mobile X-ray screening initiative for tuberculosis. And for this, we have with us Sri Ramesh Satyavali from Fujifilm. Ramesh Satyavali is currently associated with Fujifilm India Private Limited as National Head, DR and X-ray. He carries 33 years of experience in Indian healthcare industries. He was mainly associated with X-ray, based diagnostic, imaging, digital radiography, CT arms, cath lab. Over to you, sir.
Can you start the presentation? So, good afternoon to all the dignitaries, ladies and gentlemen. I am Ramesh Satyavali from Fujifilm, and we are honored and thankful that this opportunity was given to us to share our experience of mobile X-ray screening initiative for TB. So this is what I am going to cover during my presentation. And straight I'll come to my first part of my introduction of my company. Fujifilm, founded in 1934, specializes in innovation and the creation of new values through leading edge and proprietary technology. So Japanese pioneering photography filmmaker Fujifilm has leveraged its imaging and information technology to become a global presence known for innovation in healthcare, graphic art, optical devices, highly functional materials, and other high-tech areas. Never Stop is our part of campaign, and TV Pledge is a part of that. And I'll come to the scope where this idea came to go for this kind of projects and to join hands with the TV Pledge. So now we are a Diamond Tire corporate member for this project. And mainly due to COVID-19, TV notification was badly affected or rather delayed. And all, the TV diagnostics were further spreading. That was the main challenge. And due to the lack of, easy access to the X-ray facilities, many cases go undetected because it was very important for those patients, probable patients, to come forward, which generally they do not, for the X-ray screening. So this was possible because we made it possible at the end of the patient, not patient is coming to us. So intervention was to reducing diagnostic delays by active cases finding using the handheld X-ray machine. So with this, we designed a van providing, doorstep awareness and mobile X-ray diagnostic with artificial intelligence tool, which I'll come in my forthcoming slides. And when we joined hands with the project partners, our existing corporate TV Pledge partners like Apollo Tires, Ambuja Cements, Gale India, and TCI Foundation, along with, this community volunteers. Community volunteers were our CTP partners and their teams and ASHA workers and Anganwadi workers who are basically employed on honorarium basis. And their job was mainly to create the awareness and the community mobility. And that was the job which was the basic need of the project. And this sputum collection and its transportation to the areas where the van was going, and follow-up of, hard-to-reach cases. These were the main objectives which was driven by this, and we chose strategic locations and population also that was, from truckers, migrant workers, slum dwellers, and rulers and semi-urban areas in 27 districts of 9 states. And these states were Chandigarh, Punjab, Himachal Pradesh, Uttar Pradesh, Uttarakhand, Bihar, West Bengal, Chhattisgarh, Madhya Pradesh, and Rajasthan. So this was our workflow, how we basically achieved this target. Initially from our CTP partners and the project, this volunteers, first, a committee mobilization was done, a awareness program before a camp is starting. And all those presumptive cases were brought for the X-rays, where their registration was first done with their history also, means their credentials plus their brief history, which is helpful in further diagnosis and treatment, and followed by one X-ray, which is artificial intelligence-based system. And I'll come in coming slides what relevance it has. And reporting of daily patients, which was a part of the project, and sputum collection and its transportation, and further identification of those positive cases and their further treatment plan by the project partners. And finally, its registration at, next share notification. If you see, this is a wonder of technology that we can think of a 3.5 kg handheld X-ray machine. And along with a wireless detector, it's a very sensitive wireless detector for X-ray, along with a console. And this detector is antibacterial. It has an antibacterial coating, which is ideally suitable for a tuberculosis, diagnosis program. And just imagine, the moment the X-ray is done, within 3 seconds you get the image on your screen, and in less than 10 seconds you can get the complete tuberculosis score on your screen. And that is the power of AI, artificial intelligence. And once you have this image with the findings, then you have further platforms to share it with. No matter whether it's a teleradiology, it is cloud-based syncing, or anything further. So as you can see, this was done in a van where, doctors or the operators first used to have a complete registration of the patient, followed by your X-rays, and then this is how it was locating, that there was a small desk where you can have the screening of the patients, taking their history, and finally sending them for the X-ray. And now, what were the outcomes of that? In 27 districts, we covered in 9 months, and the outreach was 1 million population. And more than 12,000 X-rays were performed during this time, and around 9,000 sputum samples were tested, and 117 new TB patients were notified during this. And this was a big achievement for all of us to understand the complete operations and how to take it forward as well. This was a big learning for us. So our key lessons, our key learnings were firstly that these kind of vans really attract people to come forward and go for screening purpose. And number 2, project had provisions for X-ray films also, along with AI images for a physician to further diagnose on the film. And with the maximum outreach activities, more number of people were sensitized about the TB symptoms, screening and diagnosis, free treatment and DBT scheme. This was one of the important tasks which was done, because most of the people were not aware as to what this program is and how government is conducting, what is their role and what kind of benefits they are going to have if they are going to be positive. And so on and so forth, monitoring tools, provided by the union, and the technical support, from all our partners. And the only thing which came out as a 3 basic learnings was the higher TB rates, in certain marginalized and vulnerable communities, highlighted the need of more active symptomatic screening approach by early TB detection in these groups. Because when a van is going for 2 days, 3 days in a particular place, that would not suffice, because it needs some more time for various other activities which are associated with that. And secondly, since the follow-up was a challenge, because van was moving from one place to the other, that these are 2 challenges we found. And we also realized that, if a van is carrying this kind of X-ray equipment, then it may not be feasible to take it to some difficult to reach areas. So we basically thought of going for a smaller size of a van kind of a thing. So with this, we now have gone for a second, our project. And this project was inaugurated on September 15th, 2022 in Delhi itself. Now, we have taken lessons from our earlier projects. So now here what we are doing is, we are basically adopting 3 districts in Assam, Kerala, and Gujarat for end-to-end support. It is not only screening. It will include, adoption of maybe 100, patients for complete nutrition and further public health action on this. And we have already strengthened, facility by providing 1 CBNet or TrueNet machine to each district here. And apart from this, we are also committed to give additional 5 districts in Assam by active case finding and linkage to the TV service. So, as mentioned by all the dignitaries during a first presentation, I think we are on the track and we are committed for our role in this. And we are also thankful to Center TV Division and all state and TV TV authorities and our corporate partners, and last but not least, all those volunteers who play a key role in this. So with this, I thank you for your time. Thank you very much.
So thank you, Mr. Sayali, for a very wonderful presentation. And I think 3 points to be noted here is, we have seen a model which is presenting community mobilization. It's showing us an intervention which has supported doorstep delivery services for diagnosis. and also a very good model to see the public-public, the public-private, and the private-private engagement. So all three sorts of partnerships are being seen in this particular model where mobile screening has been done, and we all understand that this is the need of the hour. So moving to the community, giving them those diagnostic services is something which program also wants, program is also moving towards. And I thank Mr. Satyawali for this initiative which he has taken from behalf of his organization to come ahead and give this good model presentation today. I'm sure most of you will have questions on this particular session because it's something interesting for the program also to see how to carry this forward. So moving ahead to the next presentation, we have on the nutrition support model from NEA Energy. And I would request Mr. Deepak Arora, who is President Public Affairs at NEA Energy. He's an influential public affairs specialist with strong business acumen, worked closely with government in more than 10 countries, and has successfully engaged with stakeholders and contributed towards strengthening brand reputation by leveraging CSR. So over to you, Mr. Deepak, for your presentation. Thank you.
Very good afternoon to you, ladies and gentlemen, and thank you very much. And thanks to my predecessor speakers. I have a strong reputation to live up to because the presentations were really fabulous and everybody was bang on time. So I have lots of challenges to meet. Moving forward, so just giving you a little bit of a background of who we are as an organization, and then maybe I come on to the presentation. So we are an oil and gas downstream petrochemical company. Second largest private sector refining company in India with the largest network of retail outlets in the private sector. And I will be talking about our program on tuberculosis, and we are in Gujarat in two districts, Devbhoomi Dwarka and Jamnagar, which are the two adjoining districts. And this presentation will largely cover about the scope and overview, talk about the key objectives that we are trying to achieve, what is our implementation model, what have we achieved so far, and our insights into our experiences so far. So the genesis of the program was a casual chit-chat with the union team, and that's how it started. And that's how we realized that, oh yes, this is something that has really missed our attention as CSR professionals. And that's how we got into a workshop with the district health officials. There was a program that was identified, worked on, and we realized that supplementary nutrition was one key element which kind of, at least we had also oversight. We had a very strong program on malnutrition, which was focused largely on under 5, looking at the 1,000-day cycle on the young women, pregnant, lactating women. And then we realized that it was a natural evolution that could just be adopted, and we could look at this one segment which apparently had just been left out because of our ignorance on the issue. So thanks to the union team for that. And the partnership with Government of Gujarat, with the local stakeholders, technical support continuously coming in from the union as and when required. We would bounce off ideas, they would pose a challenge, and somehow it would just keep moving, and that's how the interaction started. So some of the areas where we focused on nutrition support, going forward maybe a CBNAT scheme, ecosystem strengthening and awareness, and BCC. So these have been our key focus areas. Primary objective, very clearly stated goal that we want to eradicate tuberculosis from Devbhoomi Dwarka. That's how we began. Now we have moved on to the second district, which is Jamnagar district, adjoining district, again of interest for us. Maximization of the efforts of government, like everybody else, because that's the key for sustainability. Preliminary activities, listing of patients was done jointly. Finalization of nutrition kit, again, highly customized, as you will see in the coming slides. Funds were given to the Rogi Kalyan Samiti, were required, were not required. We were doing it flexibly, directly. Community awareness on food diversity, again, linkage with our own malnutrition program was very strong, and that's how we were very successfully able to build kits that were more customized, useful. Distributing family ration kits. So the differentiation that we followed was, what we realized very early was that the nutrition kit support, that 500 rupees support which was being given, was inadequate, and especially when it was the case of women, that support would just go to the family. So what we thought was that if we can create a package, or if this nutrition support is a larger package which can probably take care of the needs of the entire family, then the chances of the affected person getting missed out, especially if it was a woman, we could minimize that. And that's how the focus was more on that larger kit. Again, a lot of support came in from our agriculture program, kitchen garden, vegetable farming. We also have a strong regional focus, and that allows us to converge different programs into one finite two districts. Yeah. Okay. So this is something that I've already given an overview. Financial support was only one element. Convergence with different programs, be it nutrition program, be it our agriculture program. And key to success, I would say, was the periodic engagement between different teams, whether it was the agriculture team. So there were stated goals that, okay, program will become sustainable only when there is a kitchen garden, only when you gradually move towards nutrition supplementation which is available in their backyard. It will only be available if there is a continuous counseling which is done by the team which was talking about the malnutrition program. So I think that package really helped us put together a comprehensive solution in Jamnagar and looking at reducing the morbidity. I will not go into this because these are all things which are very well known to you, probably more than what I know. So in some cases, funds were transferred to the district TB office. In some cases, we did it directly. When it was transferred to the TB officer, there was procurement done by them and kit were received by the TB cell. Of course, there was a continuous monitoring which was done by our team as well. There is a senior treatment supervisor which is there and a TB unit that we were talking about. So as I was saying, that clearly the goal is 100% outreach for nutrition support in 2 districts. That's a clearly stated goal. Anything less than that now may be slightly acceptable, in future is not acceptable. And not acceptable to us, not acceptable to the Prime Minister, and not acceptable to any one of us. So nutrition kits with high calorific value, food recommended by the nutritionists, as I was saying, highly customized, local food, local contents, local palate, piloted in Devbhoomi Dwarka, scaled up in Jamnagar, cross linkages with different programs, which I have already spoken about earlier. This is the composition of the nutrition kit that was formed in Dwarka, then also extended to Jamnagar district. Achievements so far, we are almost there, I would say. In the phase 1, 300 fun patients were on treatment, 250 have already been treated, another 200 new have been added. But in terms of numbers, we are very close to the goal that we want to achieve. By 2025, we are very confident that we should be able to eradicate tuberculosis completely from these 2 districts. And that's the goal that we are moving on. As you see in the table below, 333 patients, weight, no change, not survived is 1%. So there is a significant change that you will find over here in the data. In phase 2, more than 600 patients have been supported through nutrition kits. Overall, I think greater focus on adherence, follow-up, again, having multiple teams in the same geography has been really the key of success for us. Follow-up can be provided by cross-sectional teams, by different teams from different projects, and that's how really that is the key, I would say, to success. Insights and challenges. I think comparatively more patients come from low-income households. That has been our experience. Patients and families often remain low on awareness on disease management. I think one thing which we really pick up from the previous presentation by Fujifilm is looking at the mobile element of tuberculosis, because we already have mobile vans for our nutrition program, which does nutrition counseling. And we have leveraged the mobile vans in nutrition counseling. We have so far not leveraged our mobile vans in the tuberculosis diagnosis part of it. So that's a good lesson for us to look at. Tuberculosis continues to be a taboo, and greater education is really necessary around this. Household income is directly linked to the condition of the patient, and that is an extension of what I was saying as the low income group. people are the more affected ones. Children are again more affected, very well known facts to all of you. Follow-up support, necessary post-recovery and post-negative report has been really the key. Again, we intend to continue our capacity building initiatives. Going forward, we intend to stay focused on building a focused supply chain to ensure seamless support to the nutrition kits. Widespread community awareness is going to be the anchor. Concurrent monitoring, again, using multiple teams that we have in the field, is going to be the key factor for our sustained presence and sustainability thereafter. There is a joint review mechanism that has been put into place with DTO and our own team. There is a strength follow-up, continuous one, and post-treatment care that is being given. Yeah, that is what you will find on Nischay. 1344 is the number. Against that, 1146 is already reached. 375 and 311 is already there. That's where we are currently. Some of the pictures. Yeah. Thank you very much.
Thank you, sir. Thank you very much for such a nice presentations. Nutritional support model from Nyara Energy is now well established, and you have interventions in two districts, Jamnagar and Devbhoomi, Dwarka. You have mentioned about a strategic approach, development of interventions, CSR engagement, and these all are required for any sustainable response. Nowadays, many corporates, industries, and civil societies are coming forward for the nutritional support. And I think the learning from you may help further established interventions for nutritional support at the workplace and beyond. Thank you. Thank you once again for such a nice presentations. Now, moving in the row, we have the last presentations from Medanta Hospital. The corporate hospitals-led initiative by Medanta. For this, we know the several interventions have been established by Medanta Hospital at the workplace and beyond, and has shown the commitment, the larger commitment towards TB-free Haryana. For this, we have representative Dr. Bornali Datta. I think the madam has joined virtually. The madam Datta, Dr. Datta is the director, respiratory medicines at Medanta Medicity Hospital. Over to you, ma'am.
Thank you very much. I'll just start the presentation without any delay. So thank you very much for giving me the option of presenting virtually. And this is a very important forum, and I'm privileged to be here. Now, corporate hospital engagement and the Vision 2025 of a TB-free Haryana. What I'll be describing is a corporate-led multi-partner model for accelerating efforts towards a TB-free Haryana by 2025. Now, how did we begin this entire saga? Now, briefly about Medanta, the Medicity. We're a large private hospital in Gurgaon, Delhi NCR, 1250 bedded, and providing excellent clinical care. But over and above that, we have a very strong community outreach program, part of which is a TB elimination assistance to the state government for achieving TB elimination. And our initiatives to offer protection against TB in Haryana have catalyzed social well-being and development of the people. Now, there are three headings: the mobile van project called Mission TB-Free Haryana, a public-private partnership that has been on the ground from 2015. More recently, Adopt a District and Medanta DR TB Center. These are all the initiatives towards TB elimination that Medanta has been part of. The mobile van project, Mission TB-Free Haryana, this is the typical kind of van that we have, which I will go into a slide more detail, and that's Dr. Trahan launching the first van, which was given by Oriental Bank of Commerce. Now, this was the launch in November 2015, and as you can see, it is luminaries who launched it. including our Honorable Chief Minister of Haryana, Shri ML Khattar, Shri Amitabh Bachchan, Dr. Naresh Trehan, of course, at the lead in Medanta, and Mr. Verma, Richard Verma, who was the ambassador from US at that time. We were privileged to be the first diamond member when the Corporate TV Pledge was launched in 2019, April. Now, what exactly does the van do? This is typically one of our vans, and we are equipped with a digital X-ray machine and a CBNAT machine. Now, the CBNAT machine is a portable version called Gene Expert Edge, which is single module and comes in a case that we open up on the platform of the van. This is all within the van. These are the kind of queues in Haryana that we cater to. And the simple format was that we worked very closely with the district TB officer of a particular district. And the district TB officer made a timetable spanning 6 to 8 weeks, depending on the size of the district. And the plan and the timetable was of PHCs and CHCs, where the van would go and park itself. The Ashas had the task of telling the villages that they covered about this initiative, and they had pamphlets to distribute, and any patient or any person who had cough more than 2 weeks, fever, weight loss, etc., was encouraged to present to the camp on such and such day at the nearest PHC. Over there, they'd have a free chest X-ray and a sputum testing, both microscopy and gene expert. And this is the kind of thing we would, achieve, this kind of an abnormal X-ray. And then if you did a point of care diagnosis with the CBNAT, and that came positive, and that essentially expedited the whole process and prevented attrition, because we treated it as our one opportunity to capture the patient, diagnose and start treatment, notify everything. Obviously, the government has an excellent system for notification and treatment, and our team in the district then took over after diagnosis was completed. Now, this was our, how we expanded over the next few years, with 3 mobile X-ray vans operational in the entire state of Haryana. We have covered all 22 districts, starting in 2014 with a pilot with 1 district, and then going on to 5, 13, 16, and finally last year we covered all 22 districts in a cyclical manner. And this is a graphical representation of the same. The year of COVID, we took a hit, as did everyone else with TB diagnosis and treatment, but then we've recovered, well recovered. 35,000 people or more have been screened by this active case finding strategy, and more than 5,000 patients diagnosed and started on treatment, and many have completed treatment by this time. Now, an extension of what we have done was then launched this year in Adopt a District. This was a program that was envisaged along with the union, who have always been a very strong support for us at all times in our encouraging our activities, showcasing our case, giving us technical expertise, connecting us, networking us with the government, state, central TB division, and everyone else. So this is the what then led on to an expansion of what we were already doing, called Adopt a District Vision 2025 TB Free Haryana. And again, we were privileged to have our Honorable CM launching this. Now, what is the concept behind this is that every district, and this is not just Haryana, all over India, every district will have a key corporate or PSU, which will be either having their office or their factory or some presence in that district. Every one, or maybe something between 2 districts, something will always be there. And it is essentially encouraging these corporates to take this on, to adopt their district towards TB elimination. I mean, maybe towards all aspects of healthcare, but at this point, because our target is TB elimination, to look at TB elimination. So how do we do this? The partnership model went like this, a multi-partnership engagement model, which is corporate-led. The union continues to give technical support and their expertise. The NTEP Haryana is, of course, the platform on which we are working, assisting, supporting, etc. Medanta is the implementing partner for this mobile van project, and corporates, give their CSR funds, resources, and whatever they deem fit towards this. Now, of course, we already have 3 mobile vans on the ground. We have 2 further vans which have gone to 2 different states, UP and Jharkhand, where we intend to start a similar program. But at the moment, we have 3 within the district, and we are encouraging the other corporates to either give us further vans or to engage in any aspect of the 360-degree care for TB. So it can start with, as we have seen all the previous corporates presented, there are many ways to get engaged: community awareness, diagnostic, treatment, nutrition, adherence and support, etc. So there's enough areas to get involved in and assist the district team who are running the program. So this was spearheaded by the state TB cell with Medanta as the implementing partner and supported by Union as CTP Secretariat under the USAID supported I Defeat TB project. And trust me, the Union, I think we're all aware, they have done a phenomenal work in drawing in so many corporates. When we started off with the CTP pledge, there was a handful. And now they are in hundreds who are all over India, and they are doing actively, they are pushing this agenda that we need to work, we need to put our 100% towards the goal of TB-free elimination. And I think it has given huge impetus to every stakeholder, and that is really good. Now, so this is the approach. This is the map of Haryana, and you can see there are 22 districts, which are all highlighted. And they can either give a diagnostic van, as we said, they can support by other resources, and a van per district would be ideal and aspirational. Where have we reached with this Adopt a District plan? And we have made very good headway, because we have an organization like RIGHT, which is a PSU in Gurgaon, supporting us. They have given us 4 vans. 2 are operational, 2 are being fabricated as we speak. Medanta takes on the task of fabricating as well as the running cost for the entire year. IOCL have agreed to give a van for Panipat. This has been all the union's effort and the state TB cell's effort. Hindustan Unilever, who make Horlicks, have said they will give nutritional support to Sonipat, all TB patients. Krishna Maruti, theirs was the van getting launched in the Adopt a District launch. Escorts in Faridabad already run a few vans. RJ Corp have given a van to Mewat. Hero Motocorp are going to give a van and running cost for 3 years, and then Jindal's in Hisar. So all of these corporates have already committed, and we are still working, trying to get others. So in the next 3 to 6 months, we may expand from having 3 vans to close to 8 vans, perhaps, if all of this goes as per. There are 3 vans which are being fabricated as we speak, so we should have that end of the year, and then a few others. So this is good. And so when we started, we had RJ Corp, OBC, beg your pardon. We had RJ Corp, OBC giving us the vans. And now we have, you can see there are 10 corporates who are willing to get engaged and support. And how has this happened? I think it's again, multi-pronged, the approach. Dr. Trehan's stature, of course, that always helps us, his vision, his leadership helps us get acknowledgement for the program we are running to get us more vans. The program is speaking for itself. People can see what we are doing, the results we are having. And then, of course, the union, who have been encouraging other corporates to join into the whole program of TB elimination and also support us in it. So we have now got as the doctor mentioned, that we have every form of partnership going on. And I think this is the way forward, because we have to intensify our efforts. And then the last thing to mention is the DRTB Center that we launched in April this year. So this is the Medanta DRTB Center. It's a small building in the premise of Medanta. And this is Medanta in the map of Gurgaon, and we're encouraging other private hospitals to as well, join in with us. Now, why did we think it necessary is that drug-resistant TB is a menace, and it is on the rise. And the newer drugs for DRTB is only accessible in government centers. So we were given the approval by Central TB Division, by state, by the district, and the help from the district to get the newer medicines for patients of DRTB who continue to seek care in private sector. So we are working in close alignment and following all the government protocols and policies. And this is the RNTCP, the treatment card that the government uses, and we are using this as well, all provided by the Gurgaon DTO. So we have a huge gratitude to the Central TB Division and the state and district for enabling this, because our patients are now getting the required care that they need. and close follow-up. Every 2 weekly, they're given the medicines. And we have 14 patients now on the newer bedaquiline containing long oral regimen for 18 months. So this is working very well for us. The patients are doing well. They're all young patients. They're not on toxic injectables, etc. So key learnings, the van has reaching the unreached. I think this is the key thing. You know, there are vast distances in the rural areas, and you can see why patients will not come unless they're very sick. And so it is our duty to, you know, get to them, to present healthcare at their doorstep. And the government has already got a huge network of sub-centers, PHCs, CHCs, and all we are doing is sending our van to these areas to boost the diagnostic, attempts which are already going on. So complementing the government's efforts, filling whatever gap is critical. And this, again, we are guided by the district TB office of the state, the union, as to what is the need in that area. Constant improvisation. As things keep changing, we have to keep, improvising, because earlier it was sputum smear and microscopy, and now we have CB NAT, and we must use the tools. In our latest van program in Karnal, we are even utilizing Cure AI. So I think as technology improves, we just have to keep up. Technical support agency like the union enable better linkages with the government, documentation, etc. And I think I would give a big shout out here to them for enabling so much of it for us. Flexibility in partnership, mobilizing other corporate partners for resources. I think this is key. So everybody's doing a lot of work, but you must draw in others, because people are keen to get involved. They just don't know how. And the union are vital again for these linkages. The DRTB Center is the first of its kind in North India. Bombay already has a program like this, but in North India, for a private hospital to have a DRTB Center is the first of its kind. So I think, again, gratitude to Central TB Division and Dr. Trehan for allowing us to do this. And then mobilizing top political leadership and celebrities brings visibility and sustenance, and we are aware of that. And again, with support from multiple stakeholders, we do manage that. So thank you for your attention, and with that, I will draw to a close.
So thank you, Dr. Bernali, for a wonderful presentation. And I should not miss in saying this that Medanta has always been one of the leading supports for the corporate engagement for the TB program. And we have seen in your presentation how you started from a single van, you have got into another 8 vans now with your partnerships with other corporates, and now also the DRTB part with the DRTB Center coming up. So very overwhelming to see that it's the first in the Northeast India, and we wish you all success for the same. And we do learn from your presentation that partnership is a crucial part. And this is again one of the best examples we are seeing in your presentation for the public-private partnership and also a private-private partnership. So the way the partnership model has worked with the support of CTD, the union, and the efforts taken especially by Medanta themselves as a team is highly applaudable. So every presentation which we had today, since we are now at the end of the presentations, I would just like to convey that every presentation had a message. So we are talking about multi-sectoral engagement. We are speaking about convergence. But if we talk about the first presentation on the tea estate population, the message was clear. Employees are the strength of the organization. And I'm quoting this from our speakers who had just presented their presentations, and they were speaking about this. So when you speak about employees, employees is not just paying salaries to employees. It's also carries with them their health, their social welfare, their nutritional needs, which is a very good example which we have seen both in the tea estates of Assam as well as the model which is running in Gujarat. We also have a message about the youth. So we heard that youth are the future of the country. They are the pillars of the society. So engaging youth is another initiative which has been very, very well presented today in this session. And we all need to think how we can use this force to actually move towards elimination. This is something which is really going to give us results because they have ideas, they are innovative, and they also are strong and very energetic. So youth is one area we need to explore more. The third message which has come in from these sessions is the doorstep delivery services, especially to the hard-reach areas. So we have seen how Fujifilm has helped us go away with the mobile vans, the X-rays there down to the key populations. The same model reflected by Medanta also. And now we have to move to that, seeing the pandemic which we have all gone through, where there was a lot of interruption in the services of TB. So there's a very strong need to move to a model which is cost-effective and enables everybody to have access to health services, even if we are in a scenario like a severe COVID-19 pandemic. So I would like the audience, before I move to the questions, to applaud all these eminent speakers, not for the support which has come. This applaud should be for the willingness to support. So everybody can support, but this willingness has come from their own end, and this is really commendable to have such partnerships. And I think the national program will agree to this, that they already have that in their goals to have multi-sector engagement. And it's not only corporate social responsibility, it is human responsibility for us to reach out to those goals of TB elimination. So a strong applaud for all our eminent speakers. Please applaud for the wonderful effort they have given to us and for it. So I'll open the question and answer session now. If we have any queries or any suggestions or any questions for our speakers, open to the audience, please.
Thank you so much. We would like to know more about the nutrition support that Nyara Energy is giving in Devbhoomi, Dwarka. As you said that there is some intervention from the agriculture department within your company, CSR interventions, which is extending support to the TB patients. So how this model is supporting the TB patients, because there is kitchen gardening, there is homestead land, nutritional crop being grown up, and it is supported. So there is important component linked to it, the financial inclusion part also, which is being given to the TB patients. So can you please throw some light on this, because nutrition is one of, as we know, that important component for the TB patients and their family members. And my second query is from the Goodrick, Assam tea estate interventions, because you are working on value chain development also, and many of your collective forum you have developed within these tea estates. And these collectives are taking benefits from the corporate interventions. How do they receive benefits from the value chain development products? Because ultimately it is again a link to the financial literacy aspects in the program, and also very important interventions. So these are two things which I would like to know from. Thank you.
Thank you very much. Okay, is it work? I hope I am audible on this. Okay. So I will divide my answer into three parts. The first part is delivery of the nutrition kit. That's part number one. And the part number two, in fact, 4 parts. Part number two is within the nutrition support, how do you do counseling? How do you provide the ecosystem support? And also, how do you ensure that there is a sustained supply of good fruits, vegetables, etc. available? So these are essentially the 4 components that I would really focus on. So the easiest part is buying food stuff and giving it to her. Where I said that rather than looking at the affected individual as a unit, we started looking at as the family as a unit. Because what we realize is that if the food or the supplements given were small in quantity, especially when it was the case of women, it would be used by others in the family, and probably the affected person himself or herself was not getting adequate nutritional support. So what we did was the size of the kit was increased to the entire family size unit. That ensured that while it was going to the entire family, but it ensured that the person who was actually affected was getting treated or was getting enough nutrition support. And there was no leakage over there per se. So that's part one. Part two, nutrition counseling. Now, since we are a very geographically focused organization, only 2 districts is what we are focusing on. So through our other program where JSI is our partner and IIPHG in Gujarat is our partner, we ensured that every person who the kit was going to and any person who was potentially in the pipeline of getting affected by tuberculosis, there was enough counseling, messaging on good nutrition going. That was the second part of it. Third part came from our agriculture program. Again, advantage with us is that we are a geographically focused organization and we can go deeper as much as we want. So there are agriculture specialists, there are horticulture specialists, there are livestock specialists, all in the team. So what they would do is that they would go, give a kitchen garden kit, a small packet every seasonal cycle when you need to revise those, and tell them how to grow this kitchen garden and also use the stuff, including a recipe book which is there, talking about what do you make out of all these things. So that was the part 3. And part 4 was the working with the larger system, which is the district government officials, because it is not just important that there is a linkage over there. There is also a necessity in some cases, that the same person who's impacted by tuberculosis is also supported in getting and availing other schemes of Government of India. So our advantage is we are geographically focused. We can converge multiple programs into one unit, give a focused delivery. That's been our advantage.
Thank you, Mr. Arora, for that answer. I hope your question has been answered. Yeah.
Coming to your question, sir. Thank you very much. Thank you very much for your questions. Now, tea gardens are remotely located. We have got a residential population varies from 5,000 to 10,000 depending on the size of plantations. The industry is 150 years old, maybe more. So the industry looks after the total health of the population, and it is governed by the Plantation Labor Act. From birth to death, it is the responsibility of the management to look after their health and other welfare activities. Now the workers are provided with a residential accommodation. Now with the change of time, there are a lot of migration has taken place, so people have also gone out. So it's a labor-intensive industry, so the labor shortages are taking place. So in some of the gardens, which are nearer to the cities or to the nearby towns, there we have got shortage of laborers. So the migrant laborers, they do come, work, and in the evening they go back. Now we have got a hospital which has minimum 15 bed to 40 bed depending on the area under plantation. For every 1,720 permanent workforce, you require to have one medical officer permanently stationed there. If you have got more than 2,000 workforce, you require 2 medical officers. So we have got 1 medical officer as per law in each garden. And he is supported by a team of health assistants, the nurses, the ASA workers, they are also helping. So the worker is getting all sorts of help, not only in TB elimination program, but other public health programs like malaria, your dengue, and other diarrheal diseases, etc. So as a whole, the workers are very much well looked after, and they are working in an organized sector, though they are daily rated. Thank you.
Thank you, Dr. Prasad, for that clarification and explanation. Do we have any further questions from the audience? Yeah.
Yes, ma'am.
Yes, please.
Hello, sir. Thank you very much for all the panelists for the presentation. My name is Bharat. I am working as the state team leader for the UP Technical Support Unit based in Lucknow. I have questions to both Fujifilm and also Medanta. If you see the Fujifilms, the results, what they presented, out of 8,900 6 they screened, 117 were found positive, where the AI technology was adopted. Similarly, in Medant also, if you see, out of 35,000 whom they screened, 5,000 were found positive. How do you explain this difference in the yield? Again, quite difference in the yield. If you see in case of Fuji, just less than 1%, whereas in Medant almost 13% it is. That's one. Second question, basically for the Naira, for the CSR, the nutrition support what you're providing. Is there any? How are you selecting the patients? Is it particular geographies? Where you all work? Is it everywhere in the district? Because this is just what I wanted to know on that also, basically. 2 questions, sir. Thank you very much.
Would you like to answer?
Thank you for your question. Actually, when we talk of a percentage of the patients which were identified as positive cases, so first of all, the total sample size for those patients when we targeted in different communities, as I described, by different, this corporate partners who were already having those kind of, migrant laborers and other, these people. So what happens, that was the first phase we had undergone, and this was also to our surprise as to why this less numbers are coming as a positive, findings, of course. And when we basically further deep dive on this, then we realize that all the, cases, if you see the number of cases which were shown positive by the artificial intelligence and, further diagnosed by the medical professional, that was not basically the final, positive cases for the, I would say, tuberculosis after the sputum test was done. And especially in that particular case, sputum collection was also a challenge, as rightly it is collected, so on and so forth. So that was a lesson for us. And when we are going for our next phase, perhaps all these things are well taken care of, that it is end-to-end. It is not like that we are just diagnosing it with the positive or negative finding. It will be end-to-end, and we'll have a complete report as to what has been done on that. But it's a really good question that, how, these less numbers were observed, and it was really a lesson for us as well, so which we are going to see, and we are also going to scrutinize those existing cases as to what there should not be any kind of a false negative case. So that is what is our further, this project and a lesson for us. Thank you very much.
Okay, thank you for your question. I will try to answer it from a process point of view, not a technical, because I am not a technical person at all. So from a process point of view, what we realized very early was that the numbers were very few. Very few means very few. So it apparently appeared that the numbers weren't being recorded. But then, since we wanted the onboarding of the state officials from the very beginning, we simply went by the numbers that were given to us. That was clearly the step one. But as I was said earlier, our advantage is that we are there, and we are there in every block, every district, every village. So through our multiple programs, we could over a period sensitize and get the numbers to the fore. That was the second step. Third step, big challenge, is to get those numbers accepted. Because that also is a challenge sometimes that, okay, you think the person is a tuberculosis patient, but sometimes the system doesn't want to believe it because it's not recorded in their number. So then the step 4 becomes to push that person to get into a formal system. When I say formal system, go to the hospital, private, public, it could be anything. That's when your actual work starts. And when that happens, that's what you see, the numbers. Before that, the numbers were really less. And if you were to ask me that the numbers are accurate even now, I don't know. I really don't know. It's a continuous process. Numbers have grown from a single-digit number in Dwarka to 350 odd that you see today, and from probably 100 plus to the 1,300 plus that you see in Jamnagar. So that's how it has changed. Numbers will continue to change. We will continue to adapt. Goal is very clear. 2025 is the goal given to us. We will achieve it.
Okay, thank you, Mr. Satyavali, and Mr. Arora also for that explanation. Dr. Burnali, if you are online, would you like to respond to the question raised regarding the diagnosis?
Sure. Yeah. Thank you. So I think, what I can say for our project is that these are all symptomatic patients. So this is a systematic or targeted screening that we do. So versus mass screening, which is often done, in the absence of symptoms as well. So we are doing it only for symptomatic patients who have cough, fever, weight loss. The results are over a period of the last 7 years. So we have been kind of doing anything between 3,000 to 8,000 was the maximum, I think. And this is, of course, collated data of 22 districts. And this includes not only the ones who are positive microbiologically, which is either by smear positive or CB-NAT, but also clinically diagnosed. So there's a combination of all this. So I think it has been, the active case finding, intensive screening, and symptomatic screening. That is why we have the numbers that we do. But it's also over a fair period of time. I hope that makes it clear.
Yeah, I think that's a very clear explanation to the query which has been raised. Thank you for that, Dr. Barnali. So any further questions? Yes, please.
I am Dr. Vinod Garg, STO Rajasthan. My question is to Naira Energy. You said that funds were received by DTO. So can we receive the funds? One question. And if we receive that, in which head the funds will be kept? And then third, what are the guidelines to use these funds?
I really think I made a very bad presentation. That is, in my student days, it was said that person who's a bad student probably is the best teacher. Okay, so I'll try and answer your question. So there is a society in some of the districts for local welfare seeded by the government bodies. That's where we provide the funds. So district health, or it's called district health something, and that is where the funds are given, number one. Number two, funds were to be used for procuring of only the food kits. And as I said, there are two methods that were adopted. One, in some cases when the procurement was taking time, we have actually gone out ourselves and procured the food for distribution. So it is only the nutrition kit which required procurement and partnership. For other things, there are two parallel programs. One is nutrition for children, pregnant and lactating mothers, and the second one, a program on agriculture. The remaining funds came from these programs on counseling, on provision of kits for kitchen gardens, etc., etc. I hope that answered your question.
Sir, any remark from CTD? Can a DTO receive the funds? And then in that case, rules will have to be followed for procurement rules.
Definitely, Dr. Garg, sir, as you mentioned, the money received in the government system is a tricky thing because you have to be a transparent system when you are having some support from any of the corporate sector or any partners. Then it has to go to the government or the state's fund kitty will go, and then definitely the expenditure is to be done as per the GFR rules and as per the state financial arrangements.
Procurement happens only through GEM when it is given to the society.
So anyone from the IDFeed team wants to add anything? I think sir is still not satisfied with the answer.
So my name is Shadab. Just to add a little bit here. So what Deepak ji is sharing about is the previous work of Naira Energy when this was being done with the partnership with the district. And I remembered some discussion with the Rogi Kalyan Samiti account and then one account from NHM. But now with the new guidelines, probably they are considering to follow the guidelines in terms of adopting the TB patient as per the new government guidelines. I hope that clarifies. The model is from the previous work when we did not have guideline on adopting the patients.
Yes, Dr. Sachdeva, you want to say something?
I'll just clarify. In most states, it's actually very difficult for states, government bodies to receive funds. Some government bodies can receive funds if they have a society mode and they've registered under Society Act or a Trust Act. Having said that, you will also need a registration with a CSR this thing. So you have something which is known as a CSR form. You have to be registered with income tax authorities to receive CSR money. If at all you decide to form a society which is registered under Societies Act, have a CSR registration, have other registrations, then you have to follow the principles of your society, what your society decides to have as their agenda. Within governments, you know the example of ICMR, Indian Council of Medical Research. They receive extramural funds from various other societies, but they are very well provisioned to do that. So you have to talk to your own government principal secretaries whether you want to be enabled the provision for that, and then go ahead. So you'll have to do some homework before you do that. In fact, at one point of time, I inquired from many of my state TB officers because I had some funding available from some of the CSR, and most of them were not actually able to receive that because they didn't have provision to receive the money under the CSR. But it's not a strict no-no, you can receive. Many institutions do receive money.
Thank you, sir. That was enlightening for all of us. Yes, I see one more hand raised there at the back, please.
Ma'am, I can take the question, but after Malik, sir.
Yeah, sure.
Okay. Yeah, good afternoon. I am Dr. Rochak Saxena, WHO consultant from Chhattisgarh. So my question is specifically to Fujifilm, but others can also respond. So since we are more than 60% tribal areas and post-TB prevalence study findings, the government is very keen on upscaling the access to X-rays. So I just wanted to know partnership forums would definitely happen, but is there a possibility where the government can purchase on rental models the X-ray, the mobile X-ray vans? Thank you.
Thanks for your question. So far, we have not practiced this kind of a renting of the X-ray machines because there are a lot of regulations from the regulatory body, Atomic Energy Regulatory Board, as to how one can own the first equipment, and when it goes back, then what would be the repercussions, and so on and so forth. But definitely it is a workable model because at times people may not, maybe suppose some project has to go for 1 year or 2 years, so why to buy equipment which has a life cycle of 10 years? This is really a good idea. But definitely this is a good question, and where we can think of whether we can work out such things, and but everything has to be within the ambit of the regulatory body, and as such they do not have any issue in that. But only thing is, when equipment is taken back, then it has to be taken back as a pre-owned unit in the portals, and so many regulations are required. So nobody has provoked, or rather come forward in this way. But if this is a really time-based kind of a program, really it can be thought of. We are open to it. Yeah.
Thank you for that question, Rochak. So it opens food or thought for most of us to work that possibility. Yes, yes, Dr. Malik, please.
Thank you so much. First of all, a big congratulations to the union. 250 corporates is a milestone, is very quick and quite commendable. So a big round of applause for the team. And I also thank all the presenters of this forum for wonderful presentations, ideas, innovations, results, which are very encouraging. So I wouldn't ask questions, because whatever has been done comes in as a good complement to the efforts of the government. But there are a few points which I would want everyone to ponder upon. X-ray, all throughout, we've been talking about as a screening tool, maybe to lead us to the diagnosis of TB. But it is also now a screening tool to rule out active TB, so that we can go towards taking a heat from, what Mr. Deepak mentioned, that their experience also. When you start with an individual, you quickly realize that the need is not for that individual alone, it's for the entire family. Here also, protecting from TB is not just care to that individual who's on care or who's getting diagnosed, but once diagnosed, the rest of the family members, the rest of the co-workers who are sharing air for long duration of time at workplaces, as well as the neighbors if they are staying in slum pockets or in close compact areas, they all need that screening with the X-ray. And the next stage of taking them towards testing for TB infection. And if the infection is there, then the treatment for infection has been now brought into effect since last year as TB preventive treatment. So this is a scope of, taking care from an individual to the entire family or to the workplace contacts that I would like to throw upon as a challenge to all the corporates who are involved to think through within their existing scope of work how this component of protecting the family with TB preventive treatment can be brought in. The other point I'd like to kind of, I was really delighted to hear from Mr. Vivek when he touched on the WHO's e-Gurukul platform, and they have used it for the youth volunteers, which was very encouraging. So this Swasthya e-Gurukul platform is a knowledge-sharing platform created by the WHO Country Office for India, where Union is hosting a lot of, training materials, digital training materials. There are national trainings conducted on drug-resistant TB and TB preventive treatment. The courses have been all launched on that. So please spread this message across. There are now, it's gone beyond TB also. There are courses on mental health, courses on various other NCDs and communicable diseases which have been hosted on that. Once registered, you have access to all of that. So healthcare workers, volunteers, any level of care providers can access that. So I'll request that. We heard from Fujifilm as well as from Medanta about the vans, And we also heard the demand from the House on how that can be, what kind of models can be brought in. We heard from Medanta, anytime I look at the presentation or hear Bonali, I always see new things, and those colors of Haryana districts being adopted by various, corporates through the efforts of Medanta is really delighting. That's a model coming up for one state, Now, every state, needs to kind of look at, through the TBPMBA, the TB Pradhan Mantri TB Mukta Bharati Yojana, a lot of funding has now started pouring in, right? And diagnostics is one place where you could invest into this. So can these ideas which have been presented here be thought through at the state level to, utilize the fundings which are coming through the TB Mitra network, of course, with consensus of the TB Mitra or the corporates who are investing into it to come up with this. But what more is required beyond X-ray? We saw from Bernali's presentation about a NAT already sitting on it, which gives you the opportunity of a rapid molecular diagnosis for TB as well as rifampicin resistance. But what more can be added to that is now a test for TB infection detection. And the cascade can go in either direction, starting with an X-ray. If you have an X-ray suggestive of TB, do a NAT. If it is negative, do an infection test and see where that individual can be fit for care, either preventive treatment or actual TB disease treatment, or even drug-resistant TB for that matter. Plus, let's not forget about the comorbid conditions and the other, clinical vulnerabilities the patients have. So maybe a small auto-analyzer in that can help you look at anemia, look at diabetes, maybe a BP instruments for hypertension, maybe a weighing scale for BMI. So all those, and maybe, if you have the opportunity and the funding, tests which are screening tools for other communicable and non-communicable diseases. That can create a One Health approach. And if these vans are there per district, then they can, every village can have an opportunity of that van reaching that village once in 6 months at least. So that's how, community level screenings and population level screenings can be impacted through these interventions. Last point is about the big congratulations to Medanta again for being the first corporate hospital in North India for establishing the drug-resistant TB centers. This is becoming a model now which is being demonstrated not just to corporates in India, but also to other countries, other neighboring countries. We had a delegation of Nepal visiting Medanta recently, to learn from that and take it to the other countries in the region. But one, challenge that we have now is that out of the 250 corporates, we just have one corporate hospital here. But there is a scope now for moving this hub hospital. She did mention about moving to the geographies of the other hospitals and other private clinics within Gurgaon to try and make a hub and spoke model so that access to anybody approaching any private clinic or private hospital to this drug-resistant TB center, which is under an MOU, which has the gateway of receiving the newer drugs as per the regulatory authorities, it is not available in the open market. So these are avenues and gateways, the hub hospitals, which can be drug-resistant TB centers. We need to have many more such hub hospitals across the country. Thank you so much.
Thank you, Dr. Malik, for expanding that discussion. So your inputs have always been very guiding and motivating for all of us. And of course, you never miss on telling us where we are going to miss. So we have that opportunity, and it's very clear from your message where I think it will help the other corporates also to know where are the other areas where they can support us further. Thank you for that, Dr. Malik. So I see there are around 40 plus participants online as well. If there is anything or any question from the online participants, can you please raise your hands? Do we have any questions, Shrija, online? Okay, fine. So maybe we will now conclude the session. I think it's more than the time it was allocated to us. So I'll hand over to Ashish for the concluding remarks for the session, please.
Thank you so much. This is really wonderful having 5 presentations from the corporates, and we have heard these eminent speakers. So we have immense learning, and if I try to summarize in few points, of course, the engagement of corporate is very much required for a collective and integrated response. So the messages what we have learned, multisectoral and integrated response is very much required to strengthen national response against tuberculosis. It is extremely important to initiate interventions targeted to workers engaged in the various occupational settings and population-based intervention. It is also important that industries may make efforts to mobilize various other industries and stakeholders to scale up interventions in order to reach maximum populations towards TB elimination agenda. And last is the engagement of communities and youths are extremely important in the national programs. So thanks once again for all the speakers. And if Dr. Bharati, if you may like to add anything, or else with the permissions of dignitaries on the dais, we will close this session.
Thank you, our moderators. We are already behind the schedule. So quickly, I would like to thank our STOs who have joined from Delhi, Kerala, Punjab, Sikkim, Kashmir, Odisha, and other virtual audience who have joined us for this conference. I would like to request Dr. Malik Parmar and Dr. Sanjay Mattu to please present the token of appreciation to our speakers on the dais. So we have Dr. O.P. Prasad. He is the Senior Chief Medical Officer from Goodrick Tea, Assam. Goodrick Tea. Mr. Ramesh Satyavali. He is the National Head DR and X-ray from Fujifilm India. Mr. Deepak Arora, he's the President Public Affairs from Nayara Energy. We'll send a token of appreciation to our virtual speakers who have joined us today. We have a representative from Medanta Hospital. Sir, may I request you to please come and receive the token of appreciation for Medanta. Thank you, session moderators and our speakers of this session. We have many interesting sessions lined up post-lunch. The question that has been raised regarding Nikshay Mitra, we have a session tomorrow. So can I have the speakers for a group photo quickly? Dr. O.P. Prasad, sir, can we have you on dais? Mr. Deepak Arora, I think he just stepped out. Yeah, Ashish. Can we give the token of appreciation to our session moderators, Mr. Ashish and Dr. Bharati Kalottee? So please do the honor of. Thank you all. Ladies and gentlemen, we would break for lunch. We are already behind our schedule. Lunch arrangement has been done towards your right side extended balcony. Right side, towards your right side on the extended balcony. So we would